Persistent post-concussion symptoms can be frustrating for patients, but they can also be frustrating for clinicians because on paper, the patient may look like they should be better. Their imaging is normal. Their neurological exam may be relatively unremarkable. They were told to rest. They gave it time, and yet, weeks or months later, they still have headaches, dizziness, brain fog, visual sensitivity, exercise intolerance, neck pain, fatigue, or difficulty returning to school, work, or sport. So the question becomes, why do some patients continue to struggle after their concussion, and what are we actually supposed to treat? That is where post-concussion syndrome or persistent concussion symptoms can get clinically complex. But complex does not mean random. In most cases, ongoing symptoms are not because the patient is permanently damaged or because nothing can be done. More often, symptoms persist because one or more key systems driving the patient's presentation have not been identified, prioritized, or treated appropriately. So today, we're going to walk through a system-based approach to post-concussion recovery so you can better identify what may be driving persistent symptoms and how to simplify treatment planning. One of the biggest mistakes in concussion management is treating persistent symptoms as if they all come from the same source. A patient says, I still feel dizzy, but dizziness could be vestibular, it could be cervical, it could be visual, it could be autonomic, it could be migraine related, it could be anxiety induced, or it could be a combination of several of those. A patient says, I get headaches when I work on the computer. That could be visual strain, cervical referral, ocular motor dysfunction, dry eye, migraine physiology, autonomic dysfunction, or cognitive fatigue. This is why rest alone often fails. Rest is very helpful early after an injury, especially in the first 24 to 48 hours, but prolonged rest does not restore vestibular integration, cervical mobility, gaze stability, exercise intolerance, visual tracking, or headache regulation. Modern concussion care has moved toward active, individualized rehabilitation. The Amsterdam Concussion Statement supports early symptom-limited activity and individualized rehabilitation rather than prolonged, strict rest. The Buffalo Concussion Treadmill Test research supports using subsymptom threshold aerobic exercise to guide recovery in patients with exercise intolerance. Vestibular rehabilitation literature also supports targeted vestibular therapy for dizziness, balance, and gaze stability impairments after concussion. The clinical implication is simple. Persistent post-concussion symptoms don't just need more time, they need differential diagnosis, they need prioritization, and they need a progressive treatment plan. When I think about persistent post-concussion symptoms, I do not think in terms of one single concussion problem. I think in terms of interacting systems. The most common systems I want clinicians to consider are vestibular, cervical, autonomic, visual, emotional, cognitive and fatigue, and migraine. These categories overlap, but they give us a practical framework. Let's break them down. So, the vestibular system may be involved when patients report dizziness, motion sensitivity, imbalance, nausea, difficulty in busy environments, or symptoms with head movement. These patients may struggle in grocery stores, hallways, crowds, or when turning quickly. The cervical system may contribute when symptoms are linked to neck pain, limited range of motion, headaches starting from the neck, dizziness with neck movement, or symptom reproduction with cervical palpation or joint mobility testing. The autonomic system may be involved when patients have symptoms with position changes, sustained upright activity, heart rate changes, fatigue, lightheadedness, light and sound sensitivity, sleep dysfunction, headaches, difficulty with emotional regulation, or poor tolerance to daily physical activity. The visual system may contribute when symptoms increase with reading, screen use, tracking, focusing, navigating busy visual environments, or near work. These patients may describe eye strain, blurred vision, frontal headaches, difficulty concentrating, or needing to reread lines of text. The exertional system is important when symptoms increase with physical activity and is directly tied to the autonomic system. This is where graded aerobic testing and subsymptom exercise prescription can be very helpful. And finally, headaches are unique and one of the most common symptoms post-concussion. This matters because not all post-concussion headaches are the same. Some look cervicogenic, some look migraine-like, some are emotional, some are visually triggered, some are driven by sleep, stress, hydration, or medication overuse patterns. The key point is this: a patient does not usually fit perfectly into one box. A patient may have cervical dysfunction, feeding into headaches, visual intolerance, feeding into cognitive fatigue, vestibular sensitivity, feeding into avoidance, and autonomic dysfunction, limiting exercise intolerance. That is why persistent symptoms can feel so complicated. But this is also why a system-based framework is so useful. It helps you stop chasing symptoms and start identifying drivers. All right, so clinicians often struggle with persistent post-concussion symptoms because the symptoms overlap so much. Dizziness does not automatically mean vestibular. Headache does not automatically mean cervical. Brain fog does not automatically mean cognitive impairment. Exercise intolerance does not automatically mean the patient is deconditioned. The same symptom can come from multiple systems, and one impaired system can amplify another. For example, let's say a patient has cervical pain and vestibular sensitivity. If you start aggressive vestibular exercises before addressing severe cervical irritability, the patient may flare quickly and lose confidence because the neck is not at a level to tolerate the head movement required to stimulate the vestibular system for proper treatment and central integration. Or maybe a patient has visual motion sensitivity and autonomic intolerance. If you only give them balance exercises, they may not improve because the main limiter is actually busy visual environments and poor physiologic tolerance. Another common issue is treating everything at once. When a patient has 10 symptoms, it can be tempting to give 10 interventions. But complex cases usually need prioritization, not more exercises. So the question should be, what is the most clinically meaningful driver right now? Not how many impairments can I find? That shift really matters. So how do we start differentiating these systems? A good starting point is symptom behavior. So ask yourself, what brings the symptom on? What makes them worse? What makes them better? How long do symptoms last after a provocation? Are symptoms triggered by head movement, eye movement, neck movement, exertion, posture, screens, reading, busy environments, or cognitive load? These provocation patterns give you clues. If symptoms are worse with quick head turns walking in busy environments, or visual motion, think vestibular and visual motion sensitivity. If symptoms are worse with neck movement, sustained postures, palpation, or upper cervical loading, think cervical. If symptoms increase with heart rate elevation or upright activity, think autonomic or exertional intolerance. If symptoms are worse with reading, screens, convergence, saccades, or focusing, think visual or vestibular ocular involvement. Now, if symptoms follow a migraine-like pattern with light sensitivity, sound sensitivity, nausea, or strong headache episodes, consider a headache subtype in migraine physiology. But here's the important part. You are not just trying to label the patient, you are trying to determine treatment priority. A patient may have vestibular, cervical, and visual findings, but the primary driver might be the cervical irritability, or it might be visual intolerance, or it might be exertional dysfunction. That is where clinical reasoning comes in. The goal is not to find every abnormal test and treat all of them immediately. The goal is to identify which impairments are most connected to the patient's functional limitations and symptom irritability. One clinical point I want to emphasize is not that persistent symptoms do not mean the patient cannot recover. In fact, it's very rare that we cannot help someone achieve either full recovery or at least a significant improvement. But improvement depends on identifying the right drivers. If someone has persistent dizziness and they only receive rest, reassurance, and general strengthening, they may not improve because their vestibular or visual system was never specifically addressed. If someone has ongoing headaches and they only receive aerobic exercise, they may not improve because their cervical spine or migraine pattern was never managed. If someone cannot tolerate activity and they are only given vestibular exercises, they may not improve because their autonomic system needs graded exposure. This is the recovery puzzle. And when one piece is missed, the whole case can stall. Now, another important point is that symptoms can become self-reinforcing. A patient feels dizzy, so they avoid movement. They avoid movement, so their tolerance decreases. Their tolerance decreases, so normal activity feels more provocative. Then anxiety and symptom monitoring may increase. Then the nervous system becomes even more sensitive. That does not mean the symptoms are not real. It means that the rehab plan needs to restore tolerance gradually and safely. This is where graded exposure is so important. We want to find the right entry point. Not too easy where nothing changes, but not too aggressive where the patient crashes. But the right dose that creates adaptation. From an evaluation standpoint, I recommend organizing your assessment around systems. You might include a cervical screen, vestibular and ocular motor testing, balance and gait assessment, symptom provocation with visual motion or head movement, exertional testing when appropriate, headache classification, and a careful history around symptom triggers, recovery time, sleep, stress, activity tolerance, and return to work or return to sport demands. But again, testing is only useful if it changes your plan. Once you identify the likely drivers, treatment becomes more targeted. For vestibular involvement, that may include gaze stabilization, habituation, balance work, dynamic gait, and graded exposure to motion. For cervical involvement, that may include manual therapy, mobility, deep neck flexor training, sensory motor control, or postural endurance. For visual involvement, that may include ocular motor exercises, convergence or divergence work, screen tolerance, progression, environmental modifications, and referral when needed. For autonomic or exertional intolerance, that may include subsymptom threshold aerobic exercise, heart rate guided progressions, positional tolerance, and careful pacing. So for headache-related presentations, treatment should match the headache phenotype rather than assuming all headaches are the same. The big principle is this: match the intervention to the driver. Do not just give generic concussion exercise sheet and hope the patient adapts. Here are a few practical ways to simplify these cases. First, start with the patient's top functional limitation. Are they unable to work on screens, unable to exercise, unable to tolerate busy environments, unable to drive, unable to return to sport, unable to get through the school day? That tells you where to focus. Second, use symptom provocation patterns. Symptoms during reading point you in a different direction than symptoms during treadmill walking or symptoms during cervical rotation. Third, prioritize irritability. In a system that's highly irritable, you may need to calm it down or dose it more carefully before pushing forward with harder rehab. Fourth, do not treat every impairment equally. Rank the top 1 to 3 drivers and build the plan around those. Fifth, assess often. If the patient is not improving, do not just add more exercises. Revisit your hypothesis. Ask, did I miss a system? Is the dose too high? Is the dose too low? Is the patient avoiding too much? Is there a headache subtype I've not accounted for? Do they need referral for vision, medication management, psychology, or additional medical workup? This is what systems-based rehab really means. It's not just a checklist, it's an ongoing reasoning process. So, when you're working with a patient who has persistent post-concussion symptoms, here is the practical approach. Evaluate through a systems-based framework instead of focusing on one symptom category. Identify whether vestibular, cervical, autonomic, or visual, exertion, or headache-related impairments are the primary drivers. Use symptom provocation patterns to guide your differential diagnosis. Prioritize the impairments that are most connected to the patient's functional limitations. Progress treatment through individualized exposure and active rehabilitation when appropriate. And most importantly, simplify the case. Complex patients usually do not need a complicated plan. They need the right plan, at the right dose, in the right order. Persistent post-concussion symptoms are often more complex than simple rest and recovery. If you want a clear way to think through these cases, download the free guide for 6 concussion subtypes. It will help you better understand the vestibular, cervical, autonomic, visual exertion, and migraine-related systems that may be contributing to ongoing symptoms, and how a systems-based approach can improve clinical decision-making and rehab planning. And if you want a more structured implementation system for evaluating and managing complex concussion presentations, explore the Comprehensive Concussion Rehabilitation, Evaluation and Treatment online course, along with the Concussion and Return to Play Clinical Rehab Toolkit. Those resources are designed to help clinicians simplify assessment, treatment progression, and return to play decision-making so you can feel more confident managing these complex cases. Links to both the free download and information on the concussion rehabilitation course are in the video description below. Thanks for watching, and I'll see you in the next video.